Okay, so hello everyone, welcome back. Welcome to this month's SME Symposium. I'm sure a lot of people are still joining, but we will get started. So today's topic is going to be about how to pursue radiology in the UK. Now, this has been quite popular in the feedback forums, and it's something a lot of students want to hear about, so I'm really excited for this one. First of all, my name is Mohsen Salim. I'm one of the project managers here at SME Symposiums. And basically, let me tell you quickly for those who are joining us for the first time what SME Symposiums are. So SME Symposiums is a Department of Study Medicine Europe where we host monthly webinars, and it's really dedicated to giving you medical information on topics people are interested in, specifically IMGs who are planning on coming back to the UK after they graduate. So it's really things that are useful for them. Everyone is welcome to them and they're completely free. So today's speakers are going to be Dr. Azhar Ali, who's an ST2 Radiology Specialist Registrar, Dr. Hamza Rafiq, who is an academic FY2, and Baria Heather Shah, who is a fifth-year medical student from Sophia Medical University, so one of our own over here as well. And today's program, just briefly, so a little intro. First off, is going to be Dr. Ali, who's going to give you guys just an overview of what radiology is specifically in the UK and how it really works. Then Dr. Rafiq, who is a junior doctor who is applying soon to get into the radiology program. So he's going to be telling you about his journey. And then Baria Shah, who is a fifth year, final year medical student who is really ambitious and aspiring to become a radiologist in the UK. At the end, we are going to have a bit of an open Q&A. I encourage everyone to ask questions. So what to do is during the webinar, do not hesitate. At the bottom, there should be a Q&A box. Feel free to ask all the questions you want. At the end, I will select the most relevant ones, hopefully all of them, and we will get through them and I'll ask presenters them directly. So just before I hand it over, a big thank you to our partners and sponsors, Lectorio, which is an all-in-one study resource for medical students, and it combines learning science and medical education into one easy-to-use platform. It's something great. I'm sure it's something everyone knows about, and it's something you can't go wrong with. So I think at the end, once you fill in the feedback forms, you will get your certificate for attendance. And you will also get a discount code. I think Lectorio has quite a good offer this October on for their yearly package. And we're going to give out some handouts as well to the people who fill in the feedback forms. So this is the feedback. We'll come back to this at the end. Right, here, I'm going to, without further delay, hand it over to Dr. Azhar Ali. Thank you so much.
Thank you very much, Mohsen, for that introduction. I'm just going to share my screen. My presentation is going to be slightly interactive, so I'd need to speak to the audience. So if you could open the chat when I ask, that'd be great. Okay, so thank you, Mohsen, for allowing me to speak on this platform. My name's Azhar Ali. I'm one of the registrars in clinical radiology in the East of England training scheme. I'm also an educational fellow for the East of England School of Radiology, and I'll be here talking to you about what exactly clinical radiology is as a specialty and just how to get involved. So the outline of today's talk is, as I've said, we'll just be discussing what radiology is. I'll be trying to understand what your impressions of radiologists are, and we'll talk a bit about pursuing the career pathways, what kind of avenues you can go down. We'll touch a bit upon the application process, but I think my colleague Hamza is going to delve into that a little bit more deeper. And then I'll finish off with my own personal journey as to what inspired me to go onto this track and pursue radiology as a career. So before I get started, you'll see a QR code in front of you, and this will link to, if you point your phone cameras at it, it will point you to a website. And the question that will be asked is, what is the role of a radiologist? So I'd like you all to point your cameras and just answer the questions, and I'll share some of the results with you shortly. so we can get an idea of what the general audience's understanding of what a radiologist does is. So I'll just give you a couple of, a minute or so for that. Okay, so we're getting some answers already. And what I really want to know is, what's your understanding of radiology? What is the role of a radiologist, do you think? What do they do? What does their job entail? Okay, excellent. Fantastic. We're getting a lot of replies. All right, so I am going to share my screen here. 1 second. So can you, Mohsin, if you can confirm, you can see the word cloud?
Yep.
Okay, excellent. So interesting kind of answers revolving around image interpretation, mostly reporting of scans. X-rays is quite a hot topic here. Afraid of sunlight, sitting in the dark. Okay, so we're getting some of the traditional interpretations of what a radiologist is. Okay, so from here, what I can gather is the X-rays, image interpretation is the kind of general understanding of what a radiologist does, may or may not be sitting in a dark room, and mostly around that topic. Okay, so we'll go back to our presentation. You can see, you're back to our presentation, yes?
Yep.
Okay, excellent. Okay, so we'll come back to those points. And I want you to imagine a scenario. You have newly graduated from medical school. You're a doctor who's on call. You're either in a busy A&E or you're on acute medicine. And you see a patient who has come in with hemiparesis, facial droop. And so, your mind is going along the lines of what do you think is going on? What would you assume? So I think, generally speaking, from the Q&A, I can, okay. So generally, we'd be thinking about stroke at this point. Does the patient have a stroke? What's going on? How can I go ahead and see whether they do have a stroke or not? So here, we'll be thinking about the diagnosis. What's going on with this patient? They've come in, they've got clinical symptoms. I've got a potential clinical diagnosis, and this is where radiology really shines. So the patient will then come into the CT scanner. Presumably you are thinking that this is potentially a stroke that's going on. They'll have a CT scan of the brain. And here we can see that there's an occlusion. And occlusions in one of the major arteries that's in the brain is in the middle cerebral artery. And so you've got a diagnosis. You think, okay, wow, there's a thrombus, there's a clot in the brain that's causing the patients to have a stroke. At this point, what would happen next? Do you think we can get any answers?
Anyone who wants to speak, just pop your hands up. I'll unmute you.
Do you think we can get any answers on what we think is going on here? So Mohammed has raised his hand.
Hello, can you hear me?
Yes.
Yep.
So would it be thrombolysis in this case?
Fantastic. So, okay, thank you, Mohammed. So, okay, Mohammed has said thrombolysis. And in any case, if this was within a window of thrombolysis, absolutely. Most centers would consider thrombolysis, but this is where radiology is beginning to really shine, because as well as having a diagnostic element to our case, we also have a management element that can be provided by radiologists. So now we have centers with neuro intervention, so neuroradiology intervention. And what that essentially means is we are able to, as radiologists, use catheters and wires to go into the bloodstream, into the vessels, go into the brain, and perform a procedure called mechanical thrombectomy. And this is a revolutionary procedure. This is something that's, life-saving. Not only are we able to remove the clot itself that's there, that potentially sometimes thrombolysis can help, sometimes it doesn't help, but here we can directly visualize, we know where the clot is from the imaging, and we can go in through the use of intervention and remove the clot. And here you can see an occluded vessel. Once the thrombectomy is done, on the right side of your screen, you'll be able to see a lot of blood flow. The contrast signifies blood flow, and you'll be able to see the vessel being opened up. And this has really reshaped the way we kind of manage stroke, especially in tertiary centers where neurointervention is available. And eventually you can end up really impacting a patient's quality of life and improving patient care as a result. So this scenario was there to highlight a key factor. Radiology uses images to diagnose, monitor, but also treat patients. So it's all encompassing. With that patient, the care from admission to discharge essentially has been conducted by a radiologist. Obviously varying radiologists because of different levels of subspecialization, but radiology nonetheless. And this brings me back into kind of the role of radiologists. So as well as diagnosing, monitoring, and treating patients, a radiologist really needs to have a strong grasp of anatomy, clinical knowledge, and pathology, because with those three, you can marry up an image to a patient and help in patient care. So that's what makes you the center point of the patient care. Radiology involves multimodality imaging, so X-rays, CT scans, MR, ultrasound, and fluoroscopy. So, it's not just limited to one image modality. You've got a host of things that you can work with and that you're expected to work with. You're able to be a generalist, and you can we have a lot of excellent general radiologists, and every radiologist essentially has some degree, as a majority, a degree of general training. Or you can choose to subspecialize. So if you were particularly interested in musculoskeletal, you could subspecialize in MSK radiology or cardiothoracic radiology or breast radiology, urogyne radiology. So the host of subspecializations are available. And then we have this new breed, which is interventional radiology. And that can be divided into your vascular, non-vascular, or neurological radiology. And we've just touched upon the neuroradiology side of things. So the main message is it's not a single thing that we do. We are involved all around, and there's various subspecializations that can be done. And the importance is how crucial this is as a specialty to the patient care. So coming back to now the role of radiologist. So yes, we are integral to patient journey, and as we've mentioned, and as the audience has very aptly pointed out in image interpretation. But we're also educators, and radiologists, an important part of their role is in education and training. I'm a specialty registrar. I'm in my training program. I have a host of consultants and mentors who will sit and go through scans and teach, because essentially it's that one-to-one learning that will really help you develop your image interpretation skills. We have something called a REALM meeting, which is a radiology events and learning meeting, whereby scans that have had diagnoses that may not have been apparent or have been missed, and they're discussed. So in an environment within radiologists, everybody learns from a mistake that that in the future hopefully will be avoided. Educators also in the sense of when a young, a new trainee or new doctor comes in, well, I'm not sure how much experience you've had, but say you wanted to request a scan and you weren't really sure about, okay, this person's come in with, some abdominal pain. I'm not really sure which kind of scan to request. You might be able to go to the radiologist, and they might tell you, okay, this is the kind of scenario that you've faced you've shown me, I would recommend this kind of scan for this patient. So if it's a surgical abdomen, they might discuss a CT abdomen pelvis with you, and then tell you the rationale for why that scan is done. And we have different phases of contrast. So the role of education within radiology is quite vast, within the clinical team, within your own training, and within the wider radiological community. We're also very much part of the team. So we have here in the UK multidisciplinary meetings which are heavily cancer orientated, but can be for other kind of conditions as well, condition specific. But generally they comprise of nurses, of surgeons, of physicians, of radiologists, and the radiologist often sits near the computer, which is often located at the front of the meeting. But generally speaking, they're there to guide what the patient's management is and what the follow-up is. And so cases are discussed amongst the team as a whole to bring about the best point of patient care. And last but not least, this list, by the way, is not exhaustive. There are many roles that radiologists can undertake, but I just thought I'd pinpoint a few of the crucial ones. Radiologists are also researchers. We have to do regular audit cycles, compare our practice to what the national guidelines might say, whether we're meeting them. We have a lot of interesting cases that everybody can learn from. So we're very big on presenting cases, and where I work at Basildon Hospital, we have a keen department which regularly highlights new interesting cases that we may present at various conferences around the world. So I think this part, I'm just going to talk a little bit more about the pros and cons of radiology. Obviously, if you have an interest in imaging, that's a big plus point within itself, because your whole career is based in imaging. You do get a lot of interesting diagnostic and therapeutic challenges that might be shown, and it's a very rewarding feeling when the patient comes in, they're not quite right, we're not sure what's going on, and they go through a CT scan, and we're able to pick up a few salient findings and actually be like, oh wait, this is what's going on. And then the clinician who's treating the patient will be like, okay, I now know where I need to target my efforts. And so it's very rewarding to be able to diagnose and also treat challenging cases. And alongside that, you get a huge variety of cases that come through accident and emergency. We have this notion of run-through training. So run-through training essentially means when you get a spot, you just have to kind of do your training within those years. There's no further interview processes. There's no further hurdles you have to jump. Just as long as you do your exams, as long as you meet the training competencies, by the end, you should hopefully become a consultant. So there's a few run-through specialties across the board, and radiology is one of them. And that's a plus point, particularly if you don't like that whole notion of just going through an interview cycle again and again and again. It's a technology different specialty. We're at the forefront of new recent changes within our tech world. AI is a huge thing that's being discussed across the board, but more so technology within the interventional side. Like I said, neuro IR is something that's come about, that's changed practice, that's improved patient care, and so we get new gadgets, and it's always fun to work with. And I really like the one-to-one consultant teaching aspect. COVID has, generally speaking, affected training worldwide in many specialties. But one thing that is specific to radiology is even if somebody's at home or consultants at home, by virtue of us reading a scan on a computer, we can screen share, and a consultant will be able to refine our report, tell us what's going on with this patient. They could be miles away, and we'll still get that dedicated one-to-one teaching. And within the hospital, obviously, when you're sitting next to your consultant and you're looking at a scan that you've reported, getting direct feedback is a huge, very useful way of learning. A major factor that draws people into radiology is the amazing work-life balance that you can have. You can work as much or as little as you want within this specialty, obviously within the confines of what your trust and your hospital wants, but it is a very I've come from a medical background, so this to me is a huge difference. I am able to spend time with my family. I've got things outside of work life, that responsibilities, and I'm able to juggle everything reasonably well within this kind of career pathway that I've chosen. And like I said, in the previous slide, you've got a variety of roles that you can work with. You can take teaching to an international level. One of our consultants, Dr. Khan, he's a huge, teacher, educator, mentor, and he's created Dr. DKT, and he's able to reach about thousands of people with the sessions that he does. So you can take each role to a new level. One of the things that people might say, okay, well, radiology don't have that much patient ownership, and yes, whilst that might be true, in some respects, you are, you might not have that ward. If you are a person who really wants to, from the ward to discharge, be involved in that patient's care, then yes, you're going to miss out because you won't get that feeling. But you will get, and you may not be recognized, if you pick up a finding on the CT scan and you're like, this is what's going on with the patient. Yes, fine. But the surgeon intervenes and maybe takes out a cancer or goes into the patient management. You might not get the credit as say, but you have still made a huge difference to that patient's life by the skill that you have in reporting them. You require a wide subject knowledge basis, and this is important for exams. And there are tough exams that you have to get across. And across the board, we have a huge drive towards imaging workload. I mean, in your hospitals, you can imagine everybody who's coming through A&E, most people will get some sort of scan. And that scan increases the workload on the department and directly affects the workload of radiologists. And this last thing about turf wars. So essentially, there are specialties who like to who want to partake in image reporting, such as cardiology with cardiac MRIs and vascular surgery with some of the interventional work. But ultimately, whatever is best for patient care is what's best, right? And often you'll find in departments that the radiologist and the specialties, they work together in sort of synergistic relationship to bring about what's best for patient care. So this isn't too much of an issue. Okay, now you've decided, yes, I want to go into radiology. I'm sold. Essentially, in the UK, we have Oriel, which is our national application process. And I'm sure Hamza will touch on this in more detail. But you will be applying on a system called Oriel, and you'll fill out a self-assessment form, which is essentially about your portfolio. You will be then asked to sit an exam called the Multi-Specialty Recruitment Assessment, which is MSRA. And now this last year, they introduced a new thing where people who get top 55 in that exam nationally will get direct entry. And people who don't, they won't miss out. They will go via an interview. And in the interview process, their portfolio will be assessed. They'll get a station discussing some ethical clinical scenarios, and then they'll be ranked. And once you're ranked from number 1 to number whatever, you'll be able to rank your options and hopefully you'll get a place. But the bulk of people will have to go through interview and discuss portfolio and CV and fill out the self-assessment form. So this is comprised of your educational achievements, your commitment to the specialty, how you've shown that, audit, quality and improvement projects that you've done, any teaching that you've conducted, and finally, any research that you've done. So these 5 domains essentially form part of that self-assessment form. Now, what I would recommend everyone who is interested in radiology to do is to, number one, start with looking at what their undergraduate societies do. If you hold events pertaining to radiology, if you get radiology speakers like this one, if you get, that will open your mind up to the different things that a career in radiology has. You'll get involved, you'll be able to network and meet people, and from that, you might be propelled into doing electives and SSCs. SSCs might be a term that you're not familiar with. It's a student selected component. So in medical schools here, we can take out a block where we do a project within a specific area of interest. So you can do that. You can do research projects and electives. So you might be able to travel internationally to do electives. And I really recommend you use your elective wisely and do it in a field that you might potentially see yourself going into. We have this thing of taster weeks, which is within your training. Once you've graduated and you are a house officer, you're doing your foundation training, you're allowed to have 1 to 2 weeks and to essentially have a taste of a specialty that you're interested in. And so if you do taster weeks in radiology, if you do electives in radiology, if you attend courses and go to radiology conferences, I mean, this really will tick all the boxes of somebody who is keen and wants to go into radiology. So you'll have a lot to talk about at your interview. So what's training like? Well, here we have a general structure of what the training in the UK. After graduation, you have foundation training, which is 2 years, and that will be in kind of general multi-specialties. So you might have some surgical blocks, some medical blocks, a general practice block, or a community placement block, or psychiatry. And so you get a general feel of everything. Then within that, you will apply at the end of, within F2. So before November, you'll apply. And if you apply directly to go into radiology, you can at that point, or you can choose to go into something a bit more, a bit different, and then come back to radiology. But most people nowadays generally go from F2 towards directly applying to radiology. So you have radiology split into 5 years. Your first 3 years will be your core radiology, and your 4th and 5th year will be your subspecialty interest. And then at the end of the 5th year, you may want, you'll essentially, if you've met all your competencies, you'll go into being a consultant within radiology. So you can really, from 7 years from graduation, you can complete your training and be a consultant if you didn't want to take any breaks. So in ST1, which is the first year of radiology training, you kind of understand, develop an understanding of anatomy and your scientific basis of medical imaging, which is essentially physics. So physics of MR, physics of CT, physics of ultrasound, every imaging modality, the physics of it. And that's where your FRCR Part 1 exam is. It's half is anatomy, half is physics. And you will also start to develop your general radiology reporting skills. In ST2 and 3, so see, 2nd and 3rd year, you'll go into your core rotations. You'll rotate MSK, breast, gynae, GI, and you'll really hone in on those specialties to try and get your basic competencies. You'll also at this point sit your FRCR Part 2A exam, and then you'll develop, build on your multimodality reporting, and your pathology and your general knowledge base will start to increase. ST4 and 5 or 6, if you do intervention, which is an extra year, you will do your FRCR 2B exam, and then you will go into a subspecialty interest, but you also maintain your general skill set on the side. Now, one thing that's really amazing about radiology is essentially it's like an apprentice. So just as you see here, the chef is trying to refine the food that the sous chef or his junior is making. A radiology consultant will read your report, will refine it, will perfect it into a way that you will learn from them. And so this one-to-one teaching, is essence of what radiology is about and how you learn within radiology. And I think this is probably the same across the board, and probably globally as well. I know in the US, the apprentice-style learning is very heavily is also very heavily mentioned, and perhaps Mohsin can shed light on whether that's reflected on within Europe as a whole. But generally speaking, apprentice-style learning is what's the main attraction, educational wise. So I'll go into my own journey. I graduated medical school in London, and I went into foundation training. So I completed my F1, F2, and at this point, I was very medical minded. So I undertook core medical training, which is internal medicine training, which is essentially a 2-year program, now a 3-year program, where you will go on to the physician track. So whether you want to do cardiology, GI, renal medicine, so that's what you'll have to do, is the prerequisite to that. And so whilst I was in core medical training, I found myself, at a crossroad. On one side I had medicine, but within it, I felt like, every time, for example, if I was holding the bleep, if I was going to the stroke, if a stroke call came in, I'd see the patient, and then I'd looking at the image and trying to figure out what's going on. If I saw somebody with chest pain who needed a CT pulmonary angiogram to look for whether they had a PE, I'd be trying to search for, is there a PE? And I was looking at the images, and obviously I didn't know how to interpret them. And I was like, I wish this is such a crucial thing. This essentially, my decision on whether I give X, Y, Z treatment to this patient relies on this image. So I was finding myself really drawn towards that. And then I discovered the radiology department. We also don't get much exposure at an undergraduate level. I know the UK medical schools are trying to increase the exposure, and they're doing a great job in that. But generally speaking, I didn't really get much of an exposure to radiology as a medical student. So here, now I am, 3 or 4 years post-training, and I'm looking at radiology and I'm saying, okay, wow, this is a whole new specialty that perhaps I didn't appreciate as much. And then I met the department. I thought it was an amazing place. I saw the interventional department, I saw the diagnostic side, and I really fell in love with the specialty. And I thought, okay, this is a crucial moment in my life. Do I go on this track, continue and go into, I think at the time I wanted to cardiology or something, or do I go choose radiology? And I said, actually, look, I like the imaging, I like the intervention, I like this side, and why not, explore it more? So I explored it, and then I made a decision to choose radiology ultimately. This is our department. This is not the whole department. This is some of the registrars within the department. But I chose this track, and I haven't looked back since. And alhamdulillah, I think it's an amazing opportunity. But at the same time, I would really encourage any of you in the audience who is interested in radiology, do seek advice. Go to your departments, speak to the consultants, speak to the interventionalists, the diagnostic radiologists, and see what do they do, what do they get up to, and do your electives, whether you want to do it in the UK, whether you want to do it in the States, whether you want to stay in Europe. I would highly recommend you actually find out about the specialty, because you don't know what it is until you experience it. Thank you very much, and I hope you all enjoyed that session.
Amazing. Thank you so much, Dr. Ali.
Thanks.
It was really insightful talking to radiology, and I completely agree with you on the aspect of not really knowing what it is, because early on, because I think I had the same experience until I did my elective in Basildon, where I actually saw what radiology really was. Before that, I just thought like someone said, hiding from sunlight. And that was more or less my opinion. A few people did message me some interesting questions, but I will leave them until the end, if that's okay. I'll, without further delay, pass it on to Dr. Hamza Rafiq, who is a junior doctor in his FY2, aspiring to be a radiologist.
So my name is Hamza Rafiq. As Mohsin mentioned, I'm an academic trainee currently at Basildon. I'm in my foundation year 2, and I'm going to talk to you guys a bit about applying for radiology, thinking about applying for radiology and how you can kind of go about it, and hopefully give you guys some tips Thank you firstly for having me. Firstly, I'll just start with a bit about myself. So in terms of my journey, I did biomedical sciences initially. I didn't get into medicine. And then after that, I went to Romania and spent 2 years studying medicine there. After my first year, I applied to come back to the UK. Fortunately, I got into KCL and I started again from year one. So I kind of went back a year in terms of medical education, but I still ended up qualifying from KCL, and currently I'm an academic trainee at Basildon Hospital. So hopefully my experiences in Romania allow me to kind of relate with you guys and kind of tailor my teaching and my session for you. So the first thing that I wanted to talk about, especially for European medical students, before we even think about applying for radiology, is about how you're actually going to get into the UK and working in the UK and working within the NHS. So the two ways that you look at it is either you're a European citizen studying in Europe, or you're a non-EU citizen, like an international student studying in Europe. And the way you'd apply to the UK is similar in some regards, but it's also different. So if you're a non-EU citizen, you'd have to do a bit more. So both EU and non-EU citizens will have to do an English exam, which is the IELTS, and both would have to go for a GMC registration. So a GMC registration is you just email them, reach out to them, you send them your ID, your medical diploma once you've graduated, and your IELTS exam results, and then they will call you back in for an ID check. The only difference is that if you're a non-EU citizen, you'd have to get a visa, a work visa, which is country dependent. So it will depend on the country that you're originally from and their relationship with the UK. And also you'd have to sit the PLAB 1 and the PLAB 2. I know that the UK is currently planning a UK MLE within the next few years. I'm not too sure how that would change. Maybe everyone would have to sit the UK MLE. So that's currently how it is at the moment in terms of applying to work in the UK. Once you've got your GMC registration, the most important thing is this. It's so you can search anyone's name on the GMC register within the UK just to make sure that you've actually got a legit doctor taking care of you. And the most important thing is registered with the license to practice. So with most of you guys studying in Europe, if you're studying an MD, once you've registered with a GMC, you'll be registered with a license to practice. However, if you look at myself, all medical students in the UK do a 5-year MBBS course, and we all get a provisional registration for 1 year. So we do a foundation year as provisional doctors. And then at the end of that foundation year, as you can see here on the 4th of August, I was fully registered. Fortunately for you guys that coming from Europe, because most of you have done an MD or a 6-year course, you can go straight for a full registration. You won't have to go for a provisional registration. So this is quite important when we look at timelines for radiology and we look at timelines of applications. So once you've got your registration, now you need to try and get into a hospital. So for all junior doctors in the UK, we have a system that we apply for, and then you get allocated depending on your score. Whereas with you guys, you can do a clinical observership, or you can go straight in and go through an agency and become a trust grade doctor. So I'll try and talk a bit about what are the choices, the pros and cons for clinical observership and being a trust grade doctor. So a clinical observership is kind of it does what it says on the tin. You basically observe other doctors in the UK. It might be a hospital nearby to you, and seeing how they basically go about, kind of learn the system within the NHS. Whereas an agency doctor, you'll just get put straight in and you'll start working as a doctor. So we'll start with clinical observership. So the pros of clinical observership is that it's quite easy to obtain. If you think about it, it's basically being a work experience student, but you're just a fully qualified doctor, just doing work experience. And usually at the end of it, you're offered a trust grade role within that hospital, especially if you make a good impression on consultants that you're working within that department and they really want to keep you on. They'll know that you're fully qualified, you've got a license to practice, and so they'll most likely offer you a job at the end of the clinical observership. The other thing is with the clinical observership is that you have no responsibility. So you just kind of watch, see how the system works, what are the roles and responsibilities of a junior doctor, and it allows you to ease into the system. And so you can spend those 2, 3, 4 weeks, and just then at the end of it, you know exactly what you're doing and you can go straight into the system. So it's a good way to ease in. You'll have the medical knowledge and now the system knowledge of the NHS. The cons are that it's unpaid. So especially when we're thinking about rent, living away, living out, obviously you guys are most probably living all away from any of your family homes. You're all paying rent now. As you can imagine, rent, especially if you're going to do a clinical observership within London or any of the major cities, is quite expensive. So if you're going to be living, getting unpaid for 4 weeks, just thinking about that. And also a lot of the hospitals, you have to pay to host you. So it's probably around about £200 at the moment. That might increase. Different hospitals might charge different amounts. And so that's another thing to think about. Just financially, at the beginning, you've just come from being a medical student abroad, and suddenly you're going to be unpaid for at least 4 weeks. And the hospital, you're going to pay them. The other thing is there's no decision making. So you might have just come fresh out of medical school. You want to start making decisions and be supervised whilst you're making those decisions. But as a clinical observer for 4 weeks, it might be a bit frustrating just to sit there and not be able to do much. And you legally, you wouldn't be allowed to do any clinical skills or procedures. You'd be able to take histories from patients and examine them. With an examination, you'd probably have to have a qualified junior doctor just watch you and just observe you. Just from the legal side, just to protect yourselves. Obviously, you're newly qualified doctors, so it'd be the safe thing to do is just to avoid anything that can put your license at risk. In terms of an agency, so these would be locum agencies, and with locum agencies, they are looking for you to join. So they need as many doctors as possible on their books, and they can then look for jobs for them. The good thing about an agency is that you get a salary from day one. They'll find a hospital for you, so you can tell them, I want to work in this region. 1 or 2 hospitals are very close to me. I want to work in those hospitals particularly. So that agency will look for reach out to that hospital and try and get you a contract in that hospital. The other thing is free to join an agency. So you can join multiple agencies and let them compete with each other. And one of the other things kind of going against clinical observership is that you can start clinical work immediately. For some people, this might be exactly what they want, whereas other people might want to ease in. And the other thing is, some people hate sorting out all that paperwork with hospitals and the bureaucracy of going back and forth. An agency sorts out everything for you and tries to get you a contract, because they're going to make money out of it as well. They'll just take a bit of your hourly rate. So let's say you get paid £30 an hour, the agency might get £3 an hour out of that. And so whenever you work, they're always making some sort of money that you never really know about. The cons are that you're thrown in at the deep end. So if you've been away, you haven't really known the system, you haven't had any exposure to any of the hospitals in the UK, to be thrown in the deep end is quite overwhelming for some people, especially if you're on call and you suddenly get put on nights and it's just your first week being back in the UK after 5 or 6 years away. It can be quite overwhelming. And the other thing is that there's no control over your contract with an agency. So with an agency, they might just have a contract with a certain hospital for 4 weeks, and they say, okay, you can work in cardiology there for 4 weeks. They really need a doctor. And at the end of the 4 weeks, the agency will say, okay, actually, we haven't got another job for you in that department or in that hospital. So you might be going from pillar to post from one agency to another. So those are the things to kind of just think about post-registration. And then we can move now on to radiology application. So let's say you've got either trust grade or you've done a clinical observership, you're now working in the NHS. And so now, first thing you want to think about is radiology and the competition for radiology. So when we look at competition ratios, so this is last year's round 1 competition ratios. So you can see all the specialties. I think pediatrics and another one were just missing. But as you can see, radiology, it's here. So 1,677 applicants for radiology, and only 358 posts were available. And so if you look at that, you think about 4.6 applicants per place. So it's not probably as competitive as, let's say, for example, medical school is, but you're competing with very highly driven people that have probably really want to do radiology. So although you're competing with less people, the quality of everyone applying is quite high. But one thing I just wanted, there's a caveat with this number here. So when you apply on the Oriole system that Azhar was talking about, you just tick boxes for which specialties you want to apply for. So there's about 5 or 6 specialties that all go through Oriole, and they all go through the MSRA exam. One of them is GP, one of them is anesthetics, one of them is ophthalmology. So you could be a GP, you could really want to do GP, you've never thought about radiology, but just when it comes to the application cycle, you tick your radiology, you want to apply for radiology. Or you could really want to do anesthetics, and then when it comes to the MSRA and you're applying for specialties, you just tick radiology. And all it is just a simple tick, and then you add to this number of 1,677. So there's quite a few people within this number that just ticked applying for radiology for the sake of it. And we'll talk about a bit about why they might have done that in the next few slides. So this number is quite deceptive, this 1,677. Not everyone particularly wants to do radiology in that number. And the other thing is 491 people are interviewed. So if you can get to interview, you've got quite a high chance of actually getting a place somewhere in the country. So don't be put off about with any of the competition. And then when we think about the application, when we've spoken a bit about the MSRA, so you have the portfolio, which as a junior doctor, as somebody coming back from abroad, as somebody working within the NHS, post clinical observership or post or being a trust grade, the only thing you can really work on is your portfolio. Of course, you can study for your exam. Everyone can study for them exams. But what you can really do to maximize your time now and from now onwards, if you're sold on radiology, is to start working on your portfolio. And then once you've done your portfolio, there'll be then you can start revising for the MSRA. Now, the only remember when I mentioned that a lot of people would tick just for, let's say they're doing GP and they'll just tick radiology just for the sake of it, is because the top 55 people that sit this exam, regardless of what, if they've ticked radiology, even if they want to be a GP. So let's say, for example, I really want to do GP and I sit this exam and I've ticked radiology as well. If I'm in the top 55 in the country for this exam that's applied for radiology, I'll get an acceptance for radiology. I will skip this interview stage. So although in my whole life I wanted to do GP, suddenly I'm in the top 55. I've ticked radiology as I want to apply it. I just done it for the sake of it. I've got like a place in radiology now. So that top 55 has changed the game now. So if you're thinking about anesthetics, if you're thinking about any other specialty that sits this exam, just by ticking radiology and doing really well in this exam, you can just change your career path and say, okay, I want to do radiology now. If for most people who won't be in that top 55, you'll then go to interview. And as I said, you'll talk about your portfolio, you talk about your experiences. And then in the end, you'll get an offer based on all three, a combination of all three. So rating your portfolio out of 10, the score that you get in the MSRA and the interview as well. So then when we think about the application timeline, and again, this is really important for you guys because everyone that starts in the UK usually starts around August time. That's when most junior doctors start and rotate through their rotations. Whereas you guys are coming from different countries that have completely different academic cycles. So you've got to think about, when are you joining the NHS? When does your clinical observership start, or when does your trust grade role start? Now, if it starts before the 1st of December, which is the deadline, you can still work on a portfolio, you can still apply and go straight into radiology the year after. If, for example, you join and you start your clinical observership on the last week of November, then it's probably not sensible to think about applying to radiology unless you can really smash out revision for that exam, because your portfolio will be quite weak unless you start working on it, obviously, now. If you join the NHS, or if you join as a trust grade doctor after the December 1st deadline, you can't apply for radiology that year. So you've already got to start planning now. How can I work on my portfolio? What am I going to be doing for the next year when it comes to this deadline? So you would have to wait a whole year to apply, and then another year for this application cycle to go through. So it's very important to consider that now, especially if you know roughly around what time you graduate and you get your diploma and you can start talking to the GMC. So these are really important things to think about. If you can work on your portfolio now and get a lot of it done, when you do come back to the UK, even if you join very close to this deadline, you know that, well, actually my portfolio is done. I can actually go straight for a radiology application straight away. So then we move on to the portfolio. I know I've mentioned this quite a bit, and as I touched on it as well, hopefully you can see this. So like I said, it's out of 10 points at the moment. Every year they add a few things to try and put people off and make it so that people are always trying to maximize their portfolio. So last year, it was out of 5 sections, and the max you could get in each section was 2 points. So research into a career radiology, effectively, it's taste a week is probably the easiest way to do it. So here it says over 3 days in a radiology department. Now, as you can see, this is quite vague. It doesn't say if it's a radiology department in the UK, it can be a radiology department anywhere. The only thing is, if you do spend time in a radiology department, the best thing to do is try and reflect on what you saw, write down, maybe have like a Word document or some sort of portfolio where you write down what you witnessed and how it made you feel and how it might change your impression of a career in radiology. If you do that and you go to your interview and they see that you were doing reflections as a medical student, and then you also did a taster week when you joined the NHS, you'll look like somebody that's always wanted to do radiology. You've really researched it and you know that it's something for you, and you'll definitely get 2 points. Then we go into academic achievements. So over here in the UK, medical students have a chance after their third year or even after their second year to do an IBSc, which is like an intercalated BSc. If you get a first class in that BSc, or you guys, some of you might already be graduates, you have a first class in a BSc, you'd get 2 points. If you have a 2-1, you'd get 1 point. The other thing is, like as I said, he was training as a core medical trainee. To be a core medical trainee, you do the MRCP, the first part of the MRCP, you do the first part and the second part of the MRCP. As an F1 or an F2, if you can do the first part of the MRCP or MRCS, which is if you're going down the surgical route, you can get 2 points as well. And don't worry too much about here it being during your F1 and F2. What they effectively mean is that either your first year post-graduation or your second year post-graduation. So for you guys, even if you're doing a trust grade job and you're not technically an F1 or F2, or you've done a clinical observership, all it would mean is that after you've graduated, within your first 2 years, have you sat an additional exam for medicine or surgery, even though you don't want to do them specialties, just to boost up your academic achievements. If you've got a first class in a BSc, then you don't need to do any extra work here. And if you've got a 2-1, you can possibly think about doing the MRCP or MRCS. And then there's audits and QIs. I'm not sure if you guys have as much exposure to audits where you guys study, but audits are effectively, you analyze how your department works and you compare it to national standards or national guidelines. And then sometimes you do an intervention to see if that improves it. So the best example I can give is that in the UK, the A&E departments have a 4-hour wait target. So most patients should be, or every patient should be seen within 4 hours. So a simple audit could be, how does our or my A&E, how does it actually compare in regards to the rest of the country? So I could do an audit, have a look at all the patients and look at how long it took for my A&E department to see them. And if it's over 4 hours, I can then think, okay, I've got the data to show that we're not meeting targets. I can just present that. Or what I can do is do an intervention. And then once I've done the intervention, regather the data and see if my intervention has worked. So the first one, if you just stop by presenting your data, is just a 1 cycle audit. If you do the second part, it's a 2 cycle audit. So you've completed a full audit cycle with the second one. So again, thinking about that, especially when you're thinking about coming back, thinking, okay, have I got enough time to sit down, go through data? And once I've gone through the data, do I have enough time to do an intervention and then reap the benefits of that intervention? And the most important thing here is that even if you've done an audit, it just can't be sitting on your computer. It has to be presented. So if you present it regionally, nationally, or internationally, straight away, you're getting 2 points. And that's like a major thing, because it's relatively easy to do the data part of the audit. The difficult part is to try and get it presented somewhere. So we can talk a bit about this at the end as well when it comes to being international. But if you can do the audit, make a PowerPoint presentation and submit it to some of these institutes like the British Institute of Radiology or other institutes, you can get that presented and you can get 2 points there. And then teaching is another one. So teaching, obviously, as you can probably see here, having a postgraduate teaching course. So you have to have a postgraduate teaching course or a diploma. You have to be qualified. So like I said, I'm an academic trainee at the moment. That means at the end of this year, hopefully I should get a PG cert in medical education. When I apply for radiology this year, that won't count towards my teaching because I'm still doing that course. So you'd have to have a completed teaching qualification. Even if it's something quite minor like a diploma, they'd still qualify that. The one thing that you guys can do right now is work on a major contribution to a national teaching program. So obviously, wherever you guys are tuning in from, if you can think about, like, how can I make a national teaching program And it doesn't have to be radiology based. It just has to be a medical teaching program that you do nationally within whichever country you are. And the beauty of you guys being international European medical students is that if you are doing a teaching program, let's say, for example, in Bulgaria or Romania, for the UK and for the people that you'll be discussing this with that interview, that automatically becomes an international teaching program because you were doing it internationally, you weren't doing it in the UK. So you can kind of flip it and sell the fact that you did it internationally. And especially if you've got friends in other European countries, if you link up and different people are tuning in online, that becomes an international teaching program. So it's quite an easy way for you guys to get another 2 points. And if you've got friends in the UK, if you can bring them in, just 2 countries that are international can then make an international teaching program. And then the last one is research. So to try and get 2 points in research, I'm not sure, most people probably won't have a PhD. So don't worry too much about that. The things that you can work on is to be a first author in 2 non-radiology publications or a core author in a radiology publication. Now, publication sounds like something really daunting, like, oh, I've got to come up with new research. It has to be peer reviewed. I have to like do all this statistical analysis. But one thing you can do is just case reports. So go and speak to your radiology department, wherever you guys are working or wherever you guys are studying, and ask them, is there any interesting cases that I can write up and submit to journals online? One really good journal is Eurorad. It's run by the European Society of Radiology, and they will be more than happy to see if you've got case reports coming in from wherever, Romania, Bulgaria, wherever you guys are tuning in from. They would be more than happy if you can just write an abstract on that case report and submit it to them. It gives them obviously a lot more clout, and it gives you a publication in radiology, even if it is just an interesting case that you've seen. So finally, just in terms of tips, I think one thing is, even as medical students, don't wait for you to kind of have exposure to radiology. Try and go and seek it out. Try and speak to your radiology departments wherever you are and say to them, I'm really interested in radiology. I really want to like get a bit of exposure. And if you start getting 3 days now, 5 days now, or going in on your days off or whatever it is, and you can get a certificate from your hospital or your department to say you've spent some time there, you can already think about working on that part of your portfolio and also seeing if radiology is for you or not. Then the other thing, like I said, is try to find interesting cases now. So possibly when you're doing your taster week, really show that you're really interested, and then ask them, is there any interesting cases? And for them, for example, English might not be, their English might not be great, and you might be really good at English, and you can write up a really good case report. So that registrar or that consultant can get a publication, and you can get a publication just by writing it up. And they can just, in that publication, they can talk about the imaging side, and you can just write up everything else regarding that patient. And I think the other thing is, being at IMG is definitely a strength. Everything that you do is international, just because you are in the UK. So if you think like that, and you think, well, everything I do, if it's a publication, if it's an audit, whatever it is, I can present this in my country that I'm in now, or I start submitting it to journals or conferences within the country I'm in, and you get international kind of clout and international points on your portfolio. The other thing was to try and do a clinical observership as a final year student. So if you guys are from the UK and you're coming back to the UK, try and see if you can squeeze in a observership when you're a final year student. Maybe you're on your holidays or whatever it is, so that when you've got your diploma and everything, you already had that discussion with that department that you did a clinical observership in, and you can say to them, well, actually, I'm going to get my diploma in a few months. Is it okay if I join you guys? And if you can build up those relationships early, you can go straight into just being a junior doctor, and start working on your application. And I think a very important thing is to think about when you're joining, and not also when you're joining, but also where you're joining. So think about the hospitals that you're applying for. Look at the radiology departments there. So maybe when you do your clinical observership, you might think, oh, actually, the radiology department here isn't that great. I don't think I'm going to get much joy out of them. Think about, okay, what can I do to like maximize my potential? Is there other hospitals that have really good radiology departments that I can reach out to and try and do cases with or do audits with? So that's really important as well. Like, we're fortunate at Basildon. I think Mohsin and Bariab can definitely echo when me and Azhar say what Basildon has a very good radiology department. It's very inviting for people, and everybody wants to do radiology once they've experienced the radiology department there. So definitely think about where you're applying to and when it comes and when. So just thinking about that timeline, like I discussed, are you going to be able to apply? And if you are, start prepping yourself, because you know now, even if you're a third year student or a fourth year student, you know that everyone pretty much graduates around the same time every year. And if that's very close to that December deadline, start working on your portfolio before you even graduate. And the last thing is just competition ratios can definitely be very misleading. Don't worry too much about competition ratios. They're going to increase every year, and a lot of those people won't be wanting to do radiology. So don't worry too much about that. Hopefully, once you apply, you'll realize that if you've done everything in your portfolio and you've been shown commitment from a very young, like as medical students, you can definitely get into radiology. So thank you. Thanks, guys.
Amazing. Thank you so much, Dr. Rafiq. I think that was a really insightful talk, especially for us IMGs who are coming back from a lot of places. My phone is currently blowing up with different questions, so you'll have a bit of fun at the end with them. I'm gonna pass it on to Barya Bashar, who's a final year medical student in Bulgaria in Sofia Medical University, and he'll take it from here.
So first of all, good evening, everybody. Hope you guys are having a nice Sunday. I'd like to say thanks to Dr. Azhar and Dr. Hamza, amazing talk. They really gave some inside detail about radiology. About myself, I'm a fifth year medical student studying Medical University in Sofia. And I'm just going to talk about how I really got interested in radiology, what's my kind of background in terms of how I ended up doing medicine, then what are my future plans regarding radiology, and as a medical student, what are the resources that every medical student should use, and a bit about a little bit of my personal opinion about choosing a specialty at early stage. So background about myself, I'm born and bred in Pakistan. I only moved to UK in 2010. And my plan was basically to come to UK, and I finished my college and everything in Pakistan. I had those grades to do medicine in Pakistan, but I thought, you know what, I'll come to UK and I'm going to have a better opportunity, studying in a better university, better education. But when I arrived in UK, I had a bit of family problems and personal circumstances, so I started to work. I was in full-time work for about 4 years, really left education, was working full-time, different jobs, but I wasn't satisfied. There was something like, was telling me that, what, I can do better than this, I can do kind of more, rather than just working. I was happy with working, but I wasn't kind of satisfied. So what I did was basically I stopped working and I went back to education. So what I did was I converted my grades from Pakistan, what they were, to the UK system. And then when I applied for university, I got placed for biomedical science rather than medicine, because my grades on kind of, it came up to like AS level rather than full A levels. So I got placed in Surrey to do biomedical science. No regrets, really amazing degree. I enjoyed every bit of it. It was very theory based, and it really helped me in kind of, my non-clinical use medicine. It really helped me out. So when I finished the degree, I sat for a GAMSET test to kind of, apply for graduate entry. But I think the cutoff score that year was like 61, and I was in 59. So I kind of missed the score by 2 points, and then I didn't want to wait another year. So one of my friends was in Sofia, so he said to me, you know what, come to Sofia, have a visit. And I came to Sofia, liked the city, applied for the university, and here I am. 5th year now, got 1 more year, and then I'm going to be moving back to UK to kind of, pursue my career. So that's my bit of background, how I ended up doing medicine. And now we moved to radiology, kind of, how it all started. So back in 2014 it was, and my dad had like a really kind of back pain for, it was gone about 6 months, 8 months. He went to kind of chiropractors, he went to physios, he went to osteopaths, everywhere, no solution. So one of my dad's friends said to him that, you know what, book an MRI test. I kind of knew that what MRI and CTs were, but I didn't really know that what kind of specialty, what kind of field they were. So he booked an MRI, he did an MRI, and then the report came in, just, one report explained everything, what his problem what was the issue? Basically, he had like L4 and L5 two disc bulgings. So from that point, it kind of stuck with me that there is something out there, there's some field that can help people in a way that it can help them kind of, plan their management and treatment and improve their quality of life. So that was the first kind of encounter with me with radiology, but it still was early days. So I thought, you know what, something is, I could be interested. Then I started watching YouTube videos back in 2015, 2016. I used to watch two channels. One was called Dr. Salini, I think, yeah. So he's basically a radiologist. He was regular in making his videos. What he was kind of showing is what's the day-to-day life of a radiologist, what's the expectations, what's the reality, what's the workload of a radiologist, how the work is, reporting everything. So that kind of gave us like a broad aspect of the whole radiology field. I really enjoyed that. Another channel I still watch, and they have a lot of videos that is basically based on more clinical side of things. It's called Navigating Radiology. As medical students, I would, urge everyone to kind of go and check those channels, especially Navigating Radiology. They have like amazing lecture series, especially with the CT. I got really comfortable with there. They had like a lecture series which start from, principles of CT, which explains the densities, the windowing, the Hounsfield units and everything. And then they had like lectures, for example, introduction to CT head approach and principles, or COVID-19 patient CT findings. So lectures like this. So they kind of, give you inside detail of what you're looking for, what is the kind of level of, the learning and teaching you're supposed to be doing and learning. So that helped a lot. And another thing was I met a consultant radiologist. He's been a consultant for 30 years of his career. And he said to me that there's two things, make sure if you are interested in radiology, is anatomy and pathology. Dr. Azhar mentioned earlier as well, anatomy and pathology is like, core of radiology. So, and I took a risk, anatomy in second year and pathology in fourth year. I didn't take my exams in the exam period. Not because I was ready to do the exam and pass the exam, but I wasn't comfortable with myself that I'm nowhere near ready to, have the full kind of knowledge about this subject. So I took anatomy and I took pathology, both of them over the summer period, and I retook the exam in the resit period. And, I was happy enough to kind of, go through the subjects thoroughly over the summer and study them well, because I knew that if I want to do radiology in future, these subjects has to be kind of, strong. So that helped me a lot in terms of, cementing my way of, moving towards radiology. And our radiology cycle, that bound to happen in pandemic. Before the cycle, we had pharmacology. And believe it or not, whole pharmacology was through Facebook. Sounds ridiculous, but no one kind of knew that a pandemic is going to happen and things going to go that way. Especially the universities in Europe, they kind of very face-to-face learning and teaching. They don't like kind of online kind of system and stuff. So when it comes to radiology cycle, our teachers were kind of punctual. The communication was amazing. They set up the lectures in a nice way. They divided the lectures into different kind of systems. We started, for example, with thorax and chest. Then we moved to kind of digestive system. Then we moved to MSK, neuroradiology. So the lectures were kind of, delivered in such a nice way. I guess because radiology is kind of high-tech, speciality. So they kind of knew the game for the, online teaching and stuff. So I really kind of enjoyed that cycle. I recorded those lectures. I went through them again and again. They kind of helped me how to approach the imaging, what to look for it, how to recognize the pathology and stuff. So that cycle kind of make me more comfortable that there is something that I feel comfortable. I can recognize the imaging. I have a little bit of approach and principle how to deal with imaging. So that helps a lot. And the final straw was my clinical attachment, which I luckily got in Basildon Hospital. And that's where I met Dr. Azhar and Dr. Hamza. The clinical, my placement was basically regarding endocrinology and general medicine. But any time I had free, I was going to the department. I spent some time with the consultant there. I was seeing how they're reporting, what's their day-to-day duties, what's their work-life balance, what's the load on them. kind of helped. I sat down in the consultant room one day with another colleague, and he was making a lecture for FRCR 2B, and he asked me to kind of, help him out with some of the imaging to put them in a PowerPoint and stuff. So those imagings kind of, gave me an insight that what's the reality, what's the level of, the imaging you're going to be seeing, or the level of teaching there is. So it was kind of, very like kind of high level stuff. So that kind of, made me kind of, didn't scare me, but made me more kind of, confident that I can do this. So another thing I did in clinical attachment was spend a day in interventional radiology. I went to the IR suite, got to see angiomyolipoma embolization, and then got to see 2 pleural effusion drainages, 2 kidney biopsies, and one was the liver biopsy. Apparently the patient has a hemangioma, but in the MRI, someone reported this is malignant. So they had to kind of make sure that it's not malignant, it's benign. So those procedures kind of, opened my eyes. There was the IR suite was, it was mind blowing. Everything was happening on the screen with CT guided, ultrasound guided. We showed how they did the embolization of angiomyolipoma, and that kind of, cemented my way that this is the speciality I'm just, I'm going to go for, if things go according to the plan. So that's where kind of, my kind of love for the radiologist started. So this was my journey kind of way, a few things that happened, and that kind of, assured me that this specialty is for me, and then I'm going to move forward with it. As a medical student, obviously, first thing first, we have to kind of study our syllabus and, make sure that we be up to date with that. And other than that, some books and resources that I use in terms of radiology. I know books, some people like books, some people just like, some people, books are not for them, but I think the books are like, the fundamental way of, learning a topic, making understanding, and, moving forward. So a couple of books I basically use regarding radiology. First one is called Learning Radiology and Understanding the Basic. That book is basically got about 400, 500 pages. It's nicely laid out. What it does is basically the first section of the book has the normal imaging, how the normal imaging looks, and then the second part explains the pathology. So you guys can go check it out. It has nice kind of boxes which shows take-home points, important summaries and whatever. So you can check that book. Another book which is very useful is called Radiology Made Ridiculously Simple. I'm sure everyone must have heard that book. It's got like 100 pages, not much. That book just explains the imaging and the little text. So, no long text, you're not going to sit there all day, confusing yourself, nicely laid out. So you guys can check that book as a medical student. It's a nice book if you're interested in radiology. Another book is, which I love to read, called Time or Theme. I'm not sure how you pronounce it, but it's called Time Essentials for Radiology. This book has, the reason I like this book is because it's divided into specific chapters. Like, for example, chapter 1 starts as Introduction to Radiology and different modalities, that explains how CT works, MRI works, and ultrasound EHC. Then second chapter, for example, is Chest Radiology. Next chapter is musculoskeletal, then, urogenital. So if you're interested in a certain system of radiology, or if you're kind of, interested to learn something specific about certain systems, then that's book for you. You can just go check it out as a medical student. I think they are, great way to learn and, make understanding. Another thing I'm sure everyone heard about is Radiopaedia and Radiology Cafe. Radiopaedia is basically a free resource, and they have a lot of stuff. They have about, I think, 45,000 cases regarding radiology. They have 16,000 articles. They do like a day case where, a different radiologists post a case and they discuss about it. They have events. They have like courses there. You can look for the courses and you can join radiology courses. And they have a blog where they, radiologists talk about their experiences, whatever. So this is the motto of this Radiopaedia is free for all and forever. So they have a lot of resources. And if you're obviously interested in radiology, I will highly recommend to go and check Radiopaedia. Radiology Cafe is another thing which I really love because it's divided into different sections. For example, section 1 explains you about interview dates, exam dates, all the important information regarding radiologists right there. Another section is basically for the trainees. For ST1 to all the way ST5, they have different lectures, different course series where the trainees go and study and get better what they're learning. The section I love in Radiology Cafe is called for the students. Basically, it has basically from A to Z of everything that you can kind of want to learn in radiology. They have courses for medical students. They have a section where they have different links to the conferences that if you want to join a radiology conference, it's right there. You can go sign up, whatever. They have a section for the radiology societies. If you want to join a radiology society, or if you want to engage with the radiology community, they have like British Interventional Radiology, Royal College of Radiologists Society. So they have a lot of stuff there. I will urge you guys to go and check it out yourself. Another thing I used is Radiology Masterclass, and I did use it when I was doing my cycle. They have like free tutorial for the students, where they kind of give you insight to how kind of for example interpreting a chest X-ray or looking the head CT. So they give you like a tutorial that a nice approach that you can familiarize yourself, and then you can go and they have courses which are paid, but these courses are CPD points. So obviously those CPD points are good for your CV as well and for your own learning. So Radiology Masterclass is another really nice resource for the medical students to make your understanding better about radiology. And again, YouTube and Instagram. I use Instagram a lot in terms of sometimes you're not in a mood to study books or whatever, so you can sit down, maybe watching TV or something, and you can just scroll down Instagram. I use the page called the Radiologist page. That has a lot of information, a lot of nice imaging, a lot of lovely text that explain the imaging nicely. So you can be just sitting down half an hour and you'll be learning about a chest X-ray, or a head CT, or a fracture or whatever. So there has a lot of information there on that page. So as a medical student, if you guys are interested in radiology, this page is for you guys. And Radiology Conferences, obviously, they're the best way to learn. I have done 5 conferences regarding radiology, and I did one from Radiopaedia last year. This conference was, to be frank, that it was kind of way advanced for my knowledge, but it was a good experience. It's kind of gave me an insight that this is the kind of level of teaching or level of education you're going to be learning. They had like I think more than 100 speakers, and they had like advanced lecture stream, and then had generalized lecture stream. So it was an amazing experience. I have no regrets. But the conference itself was kind of above my knowledge, and I did like a few more conferences. So conferences, radiology conferences, is a nice way to kind of familiarize yourself that this is the kind of things you'll be learning, or the reality is this, and if you be able to take that kind of education. So these are the nice resources as a medical student, and I would encourage you all to kind of go and check it out for yourself. Future plans regarding radiology. First of all, gotta finish medicine. Gotta make sure that we're a competent doctor. So we can, use our clinical skills to kind of improve patients' care, and also finish my foundation training. Another thing I want to do is involve the radiology community. I basically got lucky when I went to Basildon that obviously Dr. Azhar and Dr. Hamza said that they are very keen on kind of research. So I got involved a lot in the community. Everyone is very helpful there. When you say that you want to do radiology, and as a medical student you say you want to do radiology, they really like it. So they kind of, everyone is very helping there. I managed to do 2 audits and 2 publications which regarding radiology. So that I feel like for the CV is a major part. I also want to take some more part in audits and research. I think for the radiology you have to do kind of 1 audit per year. So that is my future plan, to get busy and get involved in audits and kind of research, and that's make my portfolio, as Dr. Hamza explained. work on the CV. That's that's important for every medical student. Everyone, should be doing things, attending conferences, seminars, lectures, taking part in teaching, doing audit research. My plan is to work my CV. So obviously, when you're going back to UK, the competition is very high. I'm not saying it's impossible to lay your feet down and get to work, but you have to kind of work hard for it. And then attend radiology-based courses and events. I'm planning to go back to UK next week. There's a radiology conference in Basildon. I'm going to take part in that. So in general, I want to attend a lot more courses which are kind of radiology-based, because I do like the speciality, and I do feel like that's my kind of going to be my future career. So that's my future plans. And a little bit of my personal opinion, choosing the specialty at an early age or early stage. We all know that medicine is like, it's a vast specialty, vast field. There is a lot in there. I'm also interested in internal medicine and maybe some GP training, but radiology is like kind of, my go-to-go. That's the first thing I want to do. So make sure you guys keep your options open. Make sure that, okay, this is something I want to do, but then there's other fields which are very interesting. You might think that you like one field, but then you might end up doing another thing, like Dr. Azhar was doing internal medicine, and then he changed his specialty to radiology. So make sure your options are open. Another thing I would recommend, to assess your skills. A lot of people I met and I basically spoke to, and they said we're in medicine because it was going to give us money. The money kind of thing is there, the element is there, but it's hard work. It needs a lot of commitment, a lot of sacrifice, a lot of work. So make sure you assess your skills. Just see what the specialty wants from you, how much you can put into it, what are the skill sets that, and if you are be able to cope with that or not. So make sure you be realistic with yourself. Make sure you see what's expectations and what's the reality. You don't want to end up in a ditch. So that's that. Gain clinical experience in the field you want. Dr. Hamza explained that obviously you guys need to try to get a clinical attachment, or if you don't get a clinical attachment, go to your department. Like I'm in Sofia, I try to go to the department in radiology. I spend some time there. Gain clinical experience, see that where you are in terms of your clinical knowledge and what the field wants from you. So that's very important. There's a lot of ways, obviously, to spend time. As long as you're dedicated, as long as that you're committed to your cause, everything will come your way. But be realistic towards your goal, and be realistic towards the specialty you want to choose. Some people have this, that they want to go to specialty, but then they have not put any effort in terms of what the specialty is, how what the expectations are, and where they stand. So make sure you are very realistic in terms of whatever you're choosing, and always choose a backup specialty. The medicine is a long degree. We're spending 6 years of your life away from your family, away from your parents, not earning money, spending all the money you have. So it's a hard hit. So make sure whatever specialty you're going to or you want to go to, you always have a backup plan to fall back to. You don't want to spend all these years and then you have nothing to fall back to. So this is very realistic, that make sure that you have a backup specialty, and really think that what you want to do, because your career is going to be about 25 years, 30 years of your life. That is a long time. So make sure that you do something that you really like, because you don't want to go to work and you want to be miserable all your life, because a long career. So you really have to think deep down that this is something you want to do, and this is what you're going to make you happy, and then go ahead. And work-life balance is important as well. Like for me, at this stage, I want a field, a specialty where I can work according to my needs. I want to have a family. I like traveling. I traveled about 35 countries so far, so I want to travel a lot more. So I want balance with work and life and my social life. Family is important. Sooner or later, I'm sure that most of us would want to have a family. So make sure you keep that kind of aspect in your mind as well. And then money comes finally. obviously working really hard, you're moving forward. So the rewards are going to be there, but it's going to be very hard work. So these are my kind of personal opinion about choosing a specialty. Make sure you're realistic with your goals. Make sure you know your limits. Make sure how much sacrifice you can put in. Make sure you know that how much pressure you can take, and how much you can give back. So I hope these kind of things helped you today. Hope you're taking something from this, and thank you very much for the talk. Enjoy your evening. And
okay, well, thank you so much, Baryab. Just before we move on, what I'm going to do is I'm going to share my screen and just ask everyone to fill in, just point your phones at this QR code. It'll take you to a link where you get the feedback form. Please, please, please do fill that in. I'm also going to make it available in the Q&A box. So if you guys click in the Q&A box, you should be able to see the answered questions, which is essentially the feedback form. So once you fill this in, you'll get a little email with a certificate of attendance, and I think a lectoria code or something. And we're also doing some giveaways for lectoria passes. Right, I couldn't agree with Baryab more, especially when we were doing our clinical attachment. We were in Basildon together, and the experience was sort of a funny one, because I think Baryab was the only person I actually met who wanted to do radiology long before we did anything in radiology, before we did any conferences, before we did any attachments or anything else. Because I remember when I met Baryab, I think this is probably one of the first things he told me, that he was interested in radiology. So he had his heart set onto it very, very early on. But as a student, I wasn't as sure what I wanted to do. The one thing I did understand, and I think this comes back to the point Baryab was making, to have genuine interest, is basically learn what you love in regards to it being a specialty, not in regards to who's in it or what department it is. Because even when we were doing our clinical attachment, I had a lot more fun in some other departments than radiology. Radiology department was absolutely great, but I think it was one of those things, when I walked into radiology or the radiology department, I was genuinely interested. It wasn't even that the consultants were nice or the other staff were nice. They were wonderful, they're absolutely great, but it actually caught my interest. And I think that's definitely the way to go. Your specialty chooses you. You don't choose your specialty. You just got to get to know enough of them to know what you want to do and what you don't want to do. I did cardiology for a week, just to confirm that is something I don't want to go to. And I absolutely confirmed that cardiology is not for me. So moving on briefly, I'm just going to quickly jump into the Q&A while you guys fill in the feedback forms. I think the first question I actually want to ask Baryab is, do you know what you want to subspecialize in and why?
For now, I want to, carry on for the clinical radiology and MSK, hopefully, because I want to kind of, I'm interested in sports medicine. So that's something I would be interested in, the MSK for the future.
Lovely, amazing. Okie dokie. So I'll address some of the questions that were popping up more often than others. I think a lot of people are asking about intervention radiology, regarding how it works, and if you have to do 5 years of diagnostic radiology, then an additional year for radiology. I think this is a question more for Dr. Rafique.
Hi, so essentially interventional radiology is part of the clinical radiology training. So you will do your first 3 years in clinical radiology, and when you choose your subspecialty, you choose it as interventional radiology. So you will have year 4, year 5, and the extra year 6. So it's not just 1 year, it's 4, 5, and 6 will be orientated towards interventional radiology, and then you will finish your training. At this point, you can choose to have further fellowships. So, people in London and elsewhere offer subspecialty fellowships. So this is if you really want to delve deeper into specific focus within interventional radiology or interventional oncology. And so you can do that as well.
Absolutely. Thank you, Dr. Ali.
I just wanted to add on to that. If you do interventional radiology, the beauty of radiology is that you can still do reporting as well. So you can still be a reporting radiologist and an interventional radiologist. Azhar can probably correct me on this. I'm not sure you can be an interventional radiologist and a reporting radiologist if you haven't done that extra year for interventional radiology.
No, that's not true. Basically, if you do clinical radiology, you can within it, part of the new radiology curriculum from the RCR incorporates procedures. So say you wanted to do thoracic or cardiothoracic radiology, you would actually be expected to know how to take a CT guided lung biopsy, for example. Say you were a GI radiologist, you would be expected to be able to do some needling. Obviously, the kind of main interventional procedures, specific vascular stuff, you would have to have done interventional radiology, but your biopsies as a general radiologist, you should be expected to do some degree of biopsies and needling skills.
Thank you.
That's right.
Thank you, guys. Okay, so the next question really comes back to what Hamza was saying in regards to a lot of people picking radiology as a sort of add-on thing with their application. And I think it's the same thing in your UCAS application when you're applying for medical school. You have 5 options and only 4 of them can be something like medicine. So a lot of people do that with dentistry. So somebody asked, what would happen if you actually get into radiology in that situation? Is that something you could quite easily drop out of, and then do you have to wait another year to reapply for what you're actually aiming for?
Mm-hmm. So, so from my understanding is, you sit the MSRA, and then the MSRA is kind of like a gateway into different specialties. So kind of everyone stays together for that assessment, and then after that assessment, you'll get interviewed individually. So you could get a radiology interview, you could get anesthetics interview. A lot of GP training schemes don't do interview, but you could get a GP interview. You could also get an ophthalmology interview. So I've got a friend who's doing ophthalmology now, who also had a radiology interview last year and also got a radiology offer. However, he was set on ophthalmology, and after his radiology offer, he still hadn't received his ophthalmology offer at that point. So he didn't reject his radiology offer. He held on to it until he had finally received the ophthalmology offer. The only problem is that you can't hold on to an offer for too long. So there's a set period for once you've got an offer, you've either got to accept it or reject it. Once you've rejected it, it will get given to someone else. You can't then say, I want to now stay within radiology. So when it comes to being accepted for radiology, if you really want to do another specialty, when you get given that offer, if you haven't received an offer from the other specialty, there's only probably a week period where you can try and hold on to that offer. After that, you've got to make a decision. Either you're going to do radiology or not. And now if you do choose to go ahead with that radiology offer and you suddenly get an offer from, let's say, ophthalmology or something, of course you can reject the offer from radiology. There's no one's saying that you have to definitely do radiology. It might look bad on your portfolio if you then somehow you do whatever specialty you decided and later on want to apply to radiology again. They'll think, well, why has this guy or this person applied to radiology previously, accepted an offer and then rejected it? Whereas if you don't accept an offer, there's no really harm in that. But accepting one and then the whole training scheme and people are then deciding, okay, we've got a person in this part of the country sorted, they start their paperwork, then it's a bit just like unprofessional as well to then reject that offer. That offer then has to probably get handed to someone else, and it just makes their life difficult. So then I'm not sure if there's some sort of blacklisting, as I can maybe touch upon that, but it won't look good if you then decide to apply to radiology in the future. I'm not sure if you wanted to add on anything to that.
Yeah, no, I think you summarized it pretty well, Hamza. I'm not aware of any sort of blacklisting or thing. I just know that I would echo what Hamza said. Only accept an offer if you're going to do it. Don't accept and reject. The thing that is for sure is if you start radiology training and then you leave radiology training, to get back into the program will be exceptionally difficult. Okay, so I'm not sure what the prerequisites are. If you have to, if you accept before you start and then reject, I don't know what happens. But in any case, only accept what you're going to do, for the professional sense and for also your own career sense.
Absolutely. I think this ties into my next question, where somebody was just wondering, one of the components that was said to be part of the application was really showing your commitment to the radiology program. So how would you do that on your application or in your interview to show that you are actually committed to seeing the program through and being a part of it?
I think in terms of commitment to specialty, it's less about showing that you're going to stay in the program. It's more about what have you done to show that you are interested in radiology. So all the things that Hamza mentioned, and also that I mentioned in the presentation, things like attending courses, conferences, doing taster weeks, doing electives, doing SSCs, all of that will build your portfolio. So the commitment to specialty section is showing your commitment before starting radiology on how eager you are to wanting to do radiology. And that will be assessed on the self-assessment by way of just acknowledging that you've done the taster, providing the evidence for it, you've done the elective, providing the evidence for it. And as well as that, on the interview, it will be a speaking point. So you can say, if you ever get asked, okay, so, and they may well ask you, okay, so what have you done to show that you're interested in radiology? And then you have a whole host of things that you can talk about at the interview.
Mm-hmm. Dr. Rafiq, do you have anything to add on to that?
Yeah, so like as I pretty much summed it up really well, it's more about just having an idea and an inclination of radiology. As you can imagine, most other specialties, they have a lot of overlap in terms of the skills that you use. If you're a surgeon or you're a physician, you still have patient contact. Whereas radiology, as a lot of people said at the beginning, you sit in a dark room and you report scans. Now, you can't say you enjoy being in a dark room and reporting scans if you've never been in a dark room and seen what a radiologist is doing. So it's more about justifying your reasoning for doing radiology through your experiences. So I can give an example. I did my taster week, and the reason I did my taster week, I specifically did it because that specific week, I just wanted to relax. And I thought, I'll do my taster week in radiology this week. I'll always finish at 5 o'clock, and it'll be a relaxed week. Little did I know that I'd be with Dr. Khan, which, as I mentioned, and he does so much teaching. So I was with him until 11 p.m. every night for that whole week. And then it wasn't just teaching, he was preparing MDT slides and things like that. And for me, like at the time, I was really annoyed. But in hindsight, that's something I can talk about in my interview. That's something I can reflect upon. And I can say, well, actually, my taster week, I actually experienced the other side of radiology. I thought it was going to be one thing and it's going to be completely different. And that's another thing for you guys. When you do have your taster weeks, it's about reflecting about what you expected going in and how you've thought about radiology coming out. And do you still want to do radiology after you've done that taster week? There's going to be certain parts of that week you find really boring and other parts you find very exciting. And the beauty of radiology is that such a broad specialty that the stuff that you find really exciting, you can subspecialize in that section. So that's one thing I think in terms of like understanding the career. It's more about using your week to try and plan out, okay, how can I do this for the rest of my life?
I absolutely agree. I think the couple of days I actually got to spend with Dr. Khan, it was really that sort of situation where we were there until 7, 8 o'clock. And he'd always turn, he's the most hardworking guy. He's extremely courteous as well. So he'll always turn around and he'll ask you, are you tired? And then you have to say no to the guy because like you can't turn around and say, yeah, I'm tired. So, but no one works harder than that guy, honestly. Actually, a follow-up question for Dr. Ali here. Seeing that they want to they want you to reflect on, okay, I've been interested in radiology for a long time, but as you said, you were doing internal medicine before. Did you find that that was an obstacle of any sort or an add-on point for you?
I think, I don't think it was an obstacle at all. I think if anything, it made me really solidify my entry into radiology. It made me, number one, I was, internal medicine or core medical training is not easy. It's it gears you up to be a medical registrar. I was in a program where I was seeing an immense amount of patients. I rotated through all my, gastro, GI, cardio, resp, renal. I rotated through pretty much every of the heavy medical specialties. And in addition, I finished my MRCP. So in that, having gone through specialties at a kind of an SHO level, and then supplementing that with the qualifications, it pushed me into understanding clinical disease in a more in-depth way. And I think in radiology now, certainly the conversations that I can have with clinicians, I think it was an advantage for me. That's personal. Not everybody may feel like that. But it's a very personal thing. It's not. I wouldn't throw it as an option for people who maybe just wanted to CV build. I definitely wouldn't do that. I would just say, find out what you're interested in. At the time, at the end of F2, I was very much focused on medicine. I was focused on, like I said, I think cardiology was the driver for me, and so. These experiences and whatever I went through allowed me to reflect, refine myself as a clinician, and really figure out that radiology was the right path for me.
Absolutely. Thank you for that. Actually, this is my personal question, because going into radiology, I think this is one of the things that bothered me the most, at least. So I just wanted a comment from you guys, really discussing the lack of patient interaction and how that makes you feel, if that's something you miss. Because when I was there, I jumped from endocrinology, where I was just having a laugh with patients. I'm an extreme extrovert. I love talking to people. I love communicating with them. And then when I was in radiology, I saw a big lack of that. So do you think that's something that dawns upon you in the specialty?
So that's an interesting question, and I think a lot of people have this notion of radiologists having a lack of patient contact, but it's not entirely true. So, for example, I have 2 ultrasound sessions a week, and I'm seeing patients, scanning them, talking to them about what's going on, looking at their images in real time, being able to explain what's going on, what's on the screen, what's happening with their symptom. If I found something, I'm able to articulate in a way that will help them understand. So that side is patient heavy. If you do, for example, intervention, all you are doing is patient contact, right? Same with breast radiology, you're doing clinics. Same with MSK, you're doing ultrasound, you're doing MSK clinics, you're doing steroid joint injections. And so people often forget that side, which is heavy patient contact. Yes, of course, you will have a bulk of your time where you will be focused on images, image interpretation, whether it's CT, MR, or plain film. And yeah, at those periods you won't, but that will be supplemented, and you can supplement it as much or as little as you want. That's why it's a specialty for the extreme introvert and the extrovert combined. So if you don't want to see patients at all, you can rotate or make a job plan such that you are just looking at images. And if you really want to be involved, then you can go and do biopsies, you can go and do ultrasound lists, you can do as much as you want. But it's in a different way, right? So you won't be clerking the patient coming in through A&E. You won't be seeing them daily on a ward round. And if that's what you like, then yeah, you'll miss that element. It's just you'll see patients, but in a different way.
Absolutely. Dr.
I just wanted to add on to that. Azhar, maybe you can also let me know if this is true. Like from my taster week as well. For example, with radiology, because it's such a broad specialty, if you do have a taster week, it's really about what you see in that week. If you just sit in a dark room with one of the radiologists for the whole week, that will just make your whole idea of radiology completely different. So try and, when you do get exposure in your taster weeks, try and make sure you're seeing as many different facets of radiology as possible. For example, I remember when I looked at my taster week, I had a breast clinic, and I thought, what the hell am I going to do in a breast clinic? Like, this is going to be the most pointless clinic for me. And then I went in there, and it was probably the most, not exciting, but something that I learned the most from that breast clinic was the amount of patient contact they have. You have a waiting room full of women all worried about having breast cancer. They have their mammograms or they have an ultrasound, and then the radiologist tells them that they don't have breast cancer. So you've got people that are coming with absolute fear, and then they're being told that their scan was all clear. And a radiologist is the one doing that. They're the ones either doing the scans, they're the ones analyzing the scans, and then they're speaking to the patient. So when we think of patient contact and we think of giving people diagnosis, breaking bad news and things like that, radiologists in certain parts of radiology are doing all of that. And the other point on intervention, which as I mentioned, is that one of our interventional consultants, Dr. Imran Saeed, who's like a guide to all of us, he calls interventional radiology image-guided surgery. And the beauty of interventional radiology compared to normal surgery is that normal surgery, your patient is knocked out under GA, whereas in interventional radiology, your patient's probably awake. And whilst you're doing a procedure, you can talk to them, you can ask them about what's going on, and have a conversation. And if you're really good at what you're doing, that won't really affect your skill. So it's something where you're a surgeon and you're still talking to your patient whilst you're doing it. So the way, like as I said, there is still patient contact there, maybe not in the forms that we've always imagined it, but still there's patient contact, and still you use the skills that you really want to when you're talking about patient contact. I'm not sure if Azhar agrees or not.
Yeah, no, I agree with what you said.
Lovely. Thank you so much, guys. Okay, a couple of last boring questions over here just to clarify some things. Is there a minimum number of points that are required for the portfolio?
So from my understanding, there's no minimum number of points. So what the MSRA is used predominantly to shortlist you for interview. Once you get to interview, that's when you bring your portfolio and you discuss your portfolio. So for example, when you apply right now, previously you'd have to bring in your portfolio and you'd basically have a book there and you talk through your portfolio. Since COVID, you now have to do, as I mentioned, a self-assessment. So you can just log online and give yourself 10 out of 10. But then when you go to interview, you've got to kind of justify the 10 out of 10. So if you've got everything, 2 points in each section, and you're very confident in speaking about it and saying, okay, this is what I did, X, Y, and Z here. For example, let's say you did a teaching program. Now, if you just taught one of your friends over WhatsApp and you've put that in your self-assessment form as 2 out of 2 points, can you justify that at an interview where they question you and say, well, how is this actually a teaching program? So when it comes to minimum number of points, you dictate how many points you put down in your self-assessment, and then you're going to have to justify that point. And if you've harshly marked yourself, and you said it really well at interview, they'll boost you up. So it's about how you sell your portfolio. So when I said like being IMGs, everything you do is international. As long as you can sell it as something international, they are going to give you the maximum points. If you say, oh, I just did a national teaching program, or I just did a national teaching program in Bulgaria, and then and they'll be like, okay, fine, that's a national, 1 point we'll give you, or whatever it is, we'll give you 1 point for that. But if you say, I did an international teaching program because I did it with Bulgarian medical students, they don't know that you studied in Bulgaria. They have no clue where you've studied. They'll just be like, oh, wow, this person's done something. So it's about how you sell it as well. So there's no minimum number of points because you decide how many points you're going to give yourself for each section. And the portfolio isn't used to mark you until the interview is over. So once the interview is over, they'll give you a mark for your portfolio, a mark for your interview, and combine that with your MSRA and give you a total mark, if that makes sense.
And they're all ranked as opposed compared to actually having a pass mark or not.
Pardon?
The portfolio marks you get at the end, they'll all be ranked, and then they'll pick.
Yeah, so they'll look at your whole application holistically and then give you a ranking within the country. And then they just work down that ranking when it comes to giving out jobs and locations.
Amazing.
Is there anything that was?
Yeah, no. So essentially, like, this is a competitive specialty. So aim for full marks, because if you have time, there's no reason why you shouldn't be able to get it. And once you submitted your application, like I think a few weeks or maybe a month later, you have to submit evidence for each and everything that you've mentioned. So you need to justify it at that point. And then the interview is They may or may not ask you. Sometimes they change the stations. I'm not sure what the stations will be this year. Last year they had ethical scenarios as well. So don't just think that they might ask you portfolio stuff. They've already covered your portfolio with your self-assessment and your evidence. They may ask you, they may not ask you, they may ask you specific ethical scenarios, but they will let you know what the interview is about before, I think 2 weeks before you actually go for it, if you are invited for it. So, aim for the max, and, you'll be able to get the max.
Wise words. I absolutely agree. Okay. Well, just to finish off, I just really want to thank our presenters.
I've got one question, Mohsin.
Sure.
To any of them. As a student, when you work on your portfolio, for example, if you do an audit of publication, can you use the same audit publication in the interview later on, or would that be just to work on your CV? Or you have to, do you understand the question? Can you complete?
So you're saying, can you use the stuff you've done at medical school?
Yeah, I mean, can you complete your portfolio as a student in advance?
So yes, so there will be factors which are fixed. For example, things like distinctions or prizes that you can only probably get in medical school. And so those factors are easier to get within medical school. With regards to research, yes, absolutely. But specifically with the audits, I would recommend, because they sometimes have caveats of more than one per year, for example. So if you've graduated and your last audit was 2 years ago, and you've done F1, F2, and you haven't done any audits within them, that will be a red flag for them, and they'll pick it up, even if you've done the audits, because in the interview they might see the discrepancy, or at the self-assessment they might see the discrepancy. So I would say the stuff that you can get done in medical school that's not variable, get done. For example, research and prizes, and then in your F1, F2, really hone in on trying to do your audits and your taster weeks and commitment to specialties. Obviously, commitment to specialty you can do within medical school as well, because there are specific sections there that you can say.
Yeah, lovely, perfect. Thank you very much.
Amazing, wonderful. Again, I just really want to thank all three of you for being here. I know it's a lot taking out of your schedule, and I know you guys are busy people. So really thank you for being here. I think it was really insightful. I think this one I really just sort of set up for me, because radiology is something I'm especially interested in. So I just really wanted to see what it was all about myself. And I think everyone else here saw that as well. I think that's us for now, until next month, where we're going to do a webinar about patient pathways in the NHS. More details on the posters and the emails that will be sent out. I will leave up the screen and I will share the feedback form again. Please do fill it in. Let me just do that now. So please do fill it in, or just point your phone at the screen, and the QR code should take you over there. Great. Thank you again, guys. Have a good evening. Take care, and we will see you next month.